All right, I think we are ready to go. Welcome, everybody. We are very happy to be with you on our usual fourth Tuesday of the month for clinical conversations. And just asking folks to keep your lines on mute as best you can. And we're going to go ahead and get started. I'm Barry Sarvet, and I'm the statewide medical director for MCPAP, and we're really pleased to have our session today focused on depression in children and adolescents. And just as a reminder, some housekeeping things is that we offer CME as usual through the Mass General Hospital CME office, and you see the instructions. The code is POPNUS. Also, tell your friends about the session, especially if you enjoy it and find it helpful. And it's available on the MCPAP website, or will be after the presentation. The slides are going to be on the MCPAP website, so feel free to just listen and not worry about having to copy things over. We encourage dialogue, so definitely feel free to raise questions. Anything that you're curious about, just put them in the chat. If you would like to be unmuted, if that's easier, just ask to be unmuted in the chat and we can unmute you at the right time. We're going to save some questions for the end if they belong, sort of separately from the presentation. And if they're kind of relevant to the presentation at the time, we'll kind of cut in and try to address your question. And at the end, please fill out your survey because we really appreciate your feedback. And also, as a reminder, next month's webinar is going to be focused on the topic of ADHD. Very interesting New York Times Magazine section article on ADHD from this weekend that might be sort of food for thought if you have a chance to read that before next month. All right, so I am going to introduce our wonderful presenter for today is Dr. Sarah Palmer. Dr. Palmer is a very good friend of MCPAP and works at UMass in Worcester. She is a board-certified child and adolescent psychiatrist and assistant professor of psychiatry at UMass. She is one of the psychiatrists at the CAN-DO program, the Center for Autism and Neurodevelopmental Disorders. And she also is one of our very own MCPAP child psychiatrists. Dr. Palmer is very passionate about educating folks and does quite a bit of continuing medical education. She is involved in an ECHO program at the Kennedy Shriver Center. She does research on attachment disorders and things related to attachment with developmentally disabled folks at the Lifeline for Families. She is a fellow of the American Psychiatric Association and a distinguished fellow at ACAP. And she teaches psychopharm and writes and does outpatient consultation liaison psychiatry at UMass. So I will hand it over to Dr. Palmer and we'll take it away.
Thank you so much. Let me get this window up. All right. So just confirming you can see my slide and not my presenter notes.
Yes.
Yep. Fabulous. All right. Welcome, everyone. We're going to be talking about pediatric depression in primary care. Real quick, I have no disclosures. I have a small private practice, and other than that, I work at UMass, as was described. An outline of what we're going to talk about today is pediatric depression in Massachusetts and why we want to make sure we are thinking about depression at the primary care level. We'll review the major depressive disorder criteria in children as well as phases of treatment. And then we'll touch on some of the evidence-based treatments for depression in children and talk about the evidence that we have as of today in the literature. So why do we care so much about pediatric depression? There's prevalence of major depressive disorder in children and adolescents that's been studied since 2016. Back then, the U.S. Preventative Services Task Force reported 2% of boys, 4% of girls aged 8 to 15 reported having major depressive disorder symptoms in the last year. As we all know, during the pandemic, attention to pediatric depression and other mental concerns increased, and the rates increased as high as 15%. And particularly in Massachusetts, it seemed that our rates exceeded that of what was reported nationally, with depression in children increasing 51% from 2016 to 2020, compared to a 26% increase nationally. So this is a headline that I think a lot of us have seen and we're familiar with, about boarding times in the emergency room when children present in mental health crisis. The thing about this that really stands out is the date here. We see it's 2018. So the question beckons, did we address this crisis? Have we worked towards improving it? This is another figure that you may be familiar with. It shows the rates of boarding in Massachusetts increasing from 2019 to 2022. And between 2019 and 2020, that increased 5 times. So the answer is, unfortunately, we did not reverse the boarding crisis. This press release from February this year shows that we've kind of stuck to 47% or so. In the adult world, we have actually decreased the boarding rates, and the fewer adults are boarding now than they did 5 years ago. But in child, we've kept it from getting worse, but we are still working on this. This is still a significant issue for children in our state. So I mentioned the U.S. Preventative Services Task Force, and I wanted to call attention to this being the general recommendations. These are not the MCPAP guidelines. But what you see here, this is what, we are getting the guidance on from the U.S. Preventative Services Task Force. And what's concerning here is that, we talk about depression being noted in children as young as 8 years old. However, when we're looking for evidence for how to screen for depression or what to do to identify depression in primary care settings, we don't have guidelines younger than 11 years old that are shown as considered quote unquote evidence-based. And this is a concern in child and adolescent psychiatry where, sometimes the evidence might not be that much because doing studies in this population is particularly difficult. But does that mean that there should be no recommendation? So that is an area where I see a gap in, what we want to work towards. We want to work towards increasing our screening, making sure that we're catching depression and mood symptoms as early as possible, even in the face of, lack of strong or significant evidence based on what studies have been able to be done or show. So in that vein, there are screening instruments that have been recommended. These are links to, you'll find PDFs. I believe you do need to be licensed with these tools in order to use them popularly or in your clinics. But these are two that are very evidence-based: the Patient Health Questionnaire for Adolescents and the Beck Depression Inventory for Primary Care. And then if you look at the MCPAP guidelines, and this comes from the MCPAP website, this guideline includes all steps from screening and identification in the primary care visit through identifying subclinical to mild depression, to moderate depression, to severe depression, to diagnosis and FDA-approved medications for depression in children. And then in the final box, you'll actually see what to do going into the future. So 4 weeks reassessment and how to use these tools to actually continually assess for the success of treatment and whether changes are indicated and whether the medications are working and what else to try. So this is a very useful tool for folks in a variety of treatment scenarios. I just want to call attention to the middle box here where they say that FDA-approved medications for depression. You see fluoxetine at ages 8+, escitalopram or Lexapro at ages 12+, and then sertraline or Zoloft. So those are the age for FDA approved. Does that mean that they might work in younger children as well? We don't have the evidence, as I'll talk about. We don't have the studies, but clinically it may be indicated and it may be helpful. Just something to think about in as we go through this talk. So looking back on the U.S. Preventative Health Services Task Force, they mentioned risk factors that might increase your index of suspicion that there might be a mood disorder underlying a child's presentation. And when you look at these risk factors, what jumps out to me is that a lot of them depend on there already being a diagnosis, or there are these other things like overweight or obesity, childhood abuse or neglect, female sex, or being born with female genitalia, prior episode of depression. So these are kinds of risk factors that came up in a lot of different scenarios from different studies that the task force sort of grouped together. But what I think might be helpful clinically is to think about social determinants of health as things that really increase our concern for mood disorders and depression and anxiety. We have read about adverse childhood experiences, or ACEs, and trying to get information from the social history for our patients can really help us understand whether we should be screening more carefully for depression or other risks. I've linked here a school-based health webinar about social determinants of health surveys, or ways of getting information about all of the social history that might indicate risk factors for patients. So this can be a useful tool for trying to systematize social history gathering, because it can help us understand risk factors more completely. So I'm going to move on to some of the criteria for depression in children. This is from our DSM-5, and I've highlighted in yellow here where we see something that's different from the adult version of diagnosing depression. So in adults, we say depressed mood. For children, depression can look like irritable behavior or irritation. So the 5 or more core symptoms every day for at least 1 2-week period representing a change from previous functioning can either have irritable mood or loss of interest or pleasure. Both can be present as well. And then the other change from the adult version is weight loss or failure to make expected weight gain. As we know, children are growing. They're meant to be getting taller. They're meant to be getting heavier. When we see a change from the expected growth curve, it does increase our index of suspicion for multiple concerns. So we would always want to be looking at medical, physical causes for loss of weight gain or stagnation and growth. But it's also important to assess for mood if we notice that there's a slowdown in the child's growth. The other symptoms that we look out for: insomnia or hypersomnia, either nearly every day, psychomotor agitation or slowing nearly every day, fatigue or loss of energy, feelings of worthlessness or inappropriate guilt nearly every day, diminished ability to think or concentrate or indecisiveness, and recurrent thoughts of death, suicidal ideation, or suicidal behavior. Now, when we are getting all this information and we consider that this is a 2-week period, that's a change from previous functioning, sometimes that's a matter of getting to know a patient over time, or sometimes that's a matter of getting a new patient and this is a new concern and you're not really sure what they were like before this initial interaction. So we rely a lot on talking to family. We rely a lot on talking to others and trying to get collateral information, as well as speaking to the child directly. It can be very helpful to get a full history that way. So the treatment outcomes that we look at, and there are different phases of treatment. So back at the MCPAP guideline, you may have noticed that there's an acute phase of treatment that's really 12 weeks and before. And then beyond the acute phase, it goes into a more stabilizing phase and then a recovery phase. When we look at treatment outcomes in depression, we can break it down even further to look at these 5 R's: response, remission, recovery, relapse, and recurrence. And basically, what this is meant to show is that we sort of expect there to be a cyclical nature to depression. We don't expect to treat depression and then have a loss of all depressed emotion or depressed feeling. Some of the depression feelings or emotions can be part of the normal human experience. So talking about that with patients can be helpful to try to discern whether the depression is something that, needs to be treated and it's an emotion that's really abnormal and impacting their ability to live their life and do what they want to do, versus they are feeling depressed because they had a serious event in their life and they're having a normal response that needs to be, validated and understood and might be helped with some therapy or some, open conversation with a loved one. But when we're looking at treatment and we initiate a treatment, we consider there to be a response to the treatment if there's at least 2 weeks of no symptoms or significant reduction in symptoms. So it can take some time to get to a treatment response, but a response does not need to be a complete eradication of depression. It can be an improvement for 2 weeks. Remission goes beyond that 2 weeks to 2 months, where there are no or very few depressive symptoms for that time. And then recovery is absence of symptoms of major depressive disorder for 2 months or more. So they can have no more than 2 symptoms to be considered in recovery from depression. A relapse is when there's a major depressive episode. So that's 2 weeks of distinct depression symptoms during a period of remission, so between 2 weeks and less than 2 months. And then recurrence is the same, a major depressive episode that happens during a period of recovery. So if they've been in treatment and have had more than 2 months of remission and recovery, there can be a recurrence again. So it can be very helpful to think about where your patient is in the process of getting treatment for their major depressive disorder, because it not only helps think about what medication options might be helpful and how to treat it, it also can help the patient understand where they are in the expected course of their treatment so that it doesn't feel like a complete loss if they start to have the symptoms again, to understand that that is part of the course of how this works and that we can work on it and that there are solutions here that can be very helpful to find a way to talk about it and frame it with the patient so that they don't feel like they're in a free fall if they start to have symptoms again. So the evidence-based treatments for pediatric depression include psychoeducation and supportive therapy, as well as pharmacotherapy. The first line for the medications is Prozac or fluoxetine. And then the second line, because 30% of patients do not remit with fluoxetine, would be sertraline, escitalopram, citalopram, venlafaxine. Third line, bupropion or Wellbutrin or duloxetine Cymbalta. We do not recommend paroxetine. There's no evidence basis for using paroxetine in children. And I'll briefly go over some of the evidence that we have for the top 3 medications that are listed both in our guidelines and here. And there is additional reading available on the other medications mentioned. We just, for the sake of time, won't be going into those in as much detail. So looking at fluoxetine or Prozac. So there was a study of 708 youths who were receiving fluoxetine, and they had a 24.1% response rate and 30.1% remission rates in 6 weeks. So that's so when we start fluoxetine, just to keep in mind, we say that it typically takes between 6 to 8 weeks of being at an effective dose for you to have a treatment response. So seeing this kind of response within 6 weeks of a study is quite significant. And this is part of why sometimes with patients, I might say, we consider a full trial to be at the 6 to 8 week mark, but oftentimes children do experience benefit earlier than the 6 weeks. So that can be helpful as a way to frame the treatment and how long someone would need to continue with the treatment to get the benefit. It outperformed placebo in multiple studies and has been FDA approved for treatment for major depressive disorder in ages 8 to 18 years old. Um, and then moving on to Zoloft or sertraline, there are pooled analyses about sertraline where it outperformed placebo. And then in other studies, it did not separate from placebo in children, but did outperform the placebo in adolescents. So it's FDA approved in a slightly older population. However, it is still quite effective. And in a pooled analysis of two 10-week randomized controlled trials comparing sertraline with placebo in 364 patients. They had reduction in baseline symptoms greater than 40% in more patients receiving sertraline versus placebo. And that's a difference of 69% versus 59% with a p-value of 0.05. So quite significant benefit, although we do see that significant placebo effect in this study as well. For Lexapro, the evidence showed that in an 8-week trial of use 6 to 17 years old, there was improvement with Lexapro or escitalopram at a mean dose of 12 milligrams per day, and they were comparable with placebo. However, in the subgroup analysis of adolescents, there was improvement greater. So we're seeing this pattern that the placebo seems to have more comparable benefit to the treatment in the younger group and closer to youth age or under 12 years old. But as the child gets older into 12 to 17, we separate out the SSRI from the placebo. And in a second 8-week trial in adolescents, 12 to 17 years old, there was a significant improvement in escitalopram versus placebo. And this was also repeated in 2 trials of 572 patients, a trend for greater rate of response and remission with escitalopram versus placebo. So these results have been replicated in multiple studies and looked at in different ways. So we see a significant benefit. And just to keep in mind that all of these studies are really focused on the acute phase of treatment. When we look at the placebo effect, which we've noticed in all 3 I've mentioned, that there was this comparison to placebo where some of these treatments seemed comparable or that the placebo effect was really strong. And we see that, that is true. And I do talk about it with my patients that, there can be significant placebo effect, especially when we're starting the treatment. But in the maintenance phase, the relapse that can happen, like we discussed about one of the 5 R's is relapse, which is after someone has been in remission and recovery, we see relapse less likely to happen in patients who've been receiving antidepressants when you compare that to placebo. So in a meta-analysis of 3 trials, relapse was less likely in children who continued fluoxetine or sertraline. And in the biggest trial, relapse occurred in fewer patients who received fluoxetine than placebo. So fluoxetine was slightly stronger at preventing relapse than sertraline, but both of those were stronger than the placebo. In a subsequent meta-analysis of 3 trials, looking at 80 individuals, they compared citalopram, fluoxetine, or sertraline with placebo, and relapse was less likely with antidepressants. And pooled relapse rate for antidepressant compared to placebo was 42 versus 67%. So the children receiving the antidepressant was 42% of relapse rate compared to 67% when taking the placebo. So that's a less than half versus nearly 70%. We're thinking about that's a significant evidence, in my opinion, to really support using fluoxetine for patients who have recurrent depression or who have major depressive disorder, who are meeting criteria. It's just a better treatment. And yeah, and I think that this evidence really speaks strongly to that. So the side effects that we talk about when we're treating with SSRIs. So these are the common side effects. And the reason that they're so common is because the serotonin receptors are throughout the body. We've got a lot of serotonin receptors in the digestive tract. So we do see a lot of abdominal pain, diarrhea, the headache that can go along with that, as well as the serotonin receptors in the brain, nausea, and those tend to resolve within 2 weeks. And I do find that starting low, considering very low doses for fluoxetine to start, especially with children, can be helpful at preventing the brunt of these side effects. But some people are more sensitive than others. The thing is if we start low and go slowly with slow increases, we're more likely to be able to build that tolerance to these side effects, and they do go away over time. It's just that, we always have a patient who might feel like, these are too significant, it's not worth it, and they won't take the medication. So it's important to think about that when you start a medication like this. Other common side effects are agitation, jitteriness, or akathisia. Akathisia is that feeling of not being able to sit still, needing to move around, and having a hard time relaxing to the point where it's pretty significant. So this is one of those side effects that can be hard to describe unless someone has experienced it, because, saying it's restlessness or feeling of sort of agitation doesn't really quite cut it. It would be the feeling of like if you're trying to drive or do something, you can't sit still in the car. I've had patients who said they needed to pull over and get out of the car to move because they really couldn't sit still. So that's it kind of gets to a little bit more of the severity. Sleep changes is something that I always warn patients about, because oftentimes sleep is one of their presenting concerns with their depression, that they're having a hard time sleeping. And it really can be a matter of, advising a child to take the medication closer to bedtime or in the morning. And it's pretty difficult to predict whether it's going to be better for them to take it in the morning versus at night, because for some it can cause drowsiness, and for others it can cause sort of wild dreams, and they feel better taking it earlier in the morning. But I kind of feel like that's sort of a conversation that's ongoing with parents and families. So the more serious side effects that we talk about, and these are situations where we get into having to talk about these side effects, and they are a little bit more frightening for parents to think about when they're starting a medication for their child. And so I've included this to sort of talk about some of the actual evidence and what how I talk about this with my patients as well. So activation, disinhibition, restlessness, hyperactivity, or insomnia, we tend to recommend decreasing the dose or stopping. And the main concern when we see this sort of disinhibition with starting an SSRI is the concern that, could it be mania? Is it a bipolar concern? We don't want to put anyone at risk if this is something that's really going to activate them. It does not mean that we think that the child has bipolar disorder. It's a much more complicated diagnosis to make, and something that we would want a referral to MCPAP and a full consultation to really get to the bottom of it. But it is a reason to consider decreasing the dose, changing the medication, and really taking very careful notes about exactly what the symptoms were. So if a parent comes in saying we started this medication and my kid, he's just been off the wall since, and we can't get them to stop, we can't get them to sit still, that would be a time where I would say, let's take a pause and let's take really careful notes about what what we're seeing, so that when the next person comes in and tries to do a consultation or evaluation, they have that like really careful record of the behaviors that happened. It's very helpful to know what happened when starting an SSRI if the irritability does act up when the SSRI is started. Cardiac events are very rare. They've been reported in escitalopram and citalopram, and these are rare adverse cardiac events in pediatric patients that we do talk about if we start one of those medications. Serotonin syndrome, that's an overstimulation of central and peripheral serotonin receptors. As I mentioned, we have serotonin receptors throughout the body, and multiple types of medications can impact serotonin. So I would always talk about the serotonin syndrome as something to look out for, especially if a new medication is started, if the child has to go to the hospital for another medical concern, to always make sure that the medical team knows that they're taking an SSRI, so that if they start another medication or need to administer another medication, that they're aware of serotonin syndrome as a potential risk. And that the parents also know what the symptoms would be that they would look out for at home. So the things that they would look out for would be increased anxiety, agitation with an altered mental status, sweating, a fast heartbeat, high blood pressure, getting really hot with gastrointestinal distress, tremor, muscle rigidity, and the muscle rigidity, myoclonus, or hyperreflexia. Those are things that happen later on in the illness. So if they start having any of the earlier symptoms, that anxiety, agitation, altered mental status, that would be a reason to go to the emergency room, or at the very least call their physician, their prescriber, and talk about it, because that's a medical emergency and it can be treated with medications as long as it's identified early on. For suicidality, this is one that's been out in the world that we have been concerned. There's lots of concern about suicidality for young people when they start the SSRI. And it's potentially associated with treatment initiation or dose increases or decreases, that we see some report of increased suicidal ideation. But since including this warning and reduced use of the SSRI, we've actually seen increased suicide rates. There's studies that show that has been noted and a concern for psychiatrists and doctors and families who are trying to treat these children, that we're concerned about it, and we decide not to use the medication because of this risk, or maybe because of other concerns. But that the timing ever since this black box warning has been included has just been associated with more risk to children. Also, when they were studied, when they look closer at these reports of suicidal ideation, they actually noticed that there's decreased completed attempts reported. So one of the things that I think about when we consider the suicidality with the SSRI initiation is that in some ways, when we reduce the depression symptoms and we treat some of that anhedonia, guilt, and poor sleep or anxiety, irritability, sometimes that leads to more conversations happening between the child and their therapist, or the child and their parent, and they might be able to open up about some of the symptoms they've been experiencing that they might not have felt able to talk about earlier. And so as the treatment continues, we might just see suicidal ideation that might have been present before we started the treatment, but was never discussed or out in the open. So I think that there's a lot of work to do as far as trying to help those conversations become more, not normalized, but more validated, acceptable, reasonable for children to have those kinds of conversations with their providers and their parents, so that we can offer help and support in a constructive way. Discontinuation syndrome is another thing to consider. So discontinuation syndrome happens when we discontinue the medication. So, and this is sort of in a separate category. So I'll just use this table to talk a little bit about each of these side effects. So this is a table from UpToDate, everybody's favorite resource, and it goes through not only what to look for each of these side effects, but also the incidence. So when we see suicidality that's listed at 2%, that akathisia that's 5 to 25%, that's the wide range, just something to always look out for. Manic swishing, I mentioned that we kind of look out for it. We don't consider it specifically a diagnosis of mania, but we do want to take careful notes. And then when we look at serotonergic syndrome, that's very rare, but just something to be aware of because it's a medical emergency. Apathy is kind of a clinical note that I appreciate that they've included here. Apathy can come up in use of SSRI for children in the same way that like loss of libido can happen in adults. In children, sometimes when they start an SSRI, say, well, I'm not feeling depressed, but I'm also not feeling anything at all. And that can be a reason to change the medication. I do prefer starting an augmenting agent like Wellbutrin, which is listed here, Wellbutrin SR, 100 milligram every morning. It's a relatively low dose and it can really help with the apathy. Now, just to backtrack a little bit to the discontinuation syndrome, this is something to be aware of when you're starting a medication, like an SSRI. And when you stop the SSRI, the symptoms that can come up are almost like flu-like symptoms. They can feel nauseous. There can be some paresthesias, fear, dizziness, vivid dreams, insomnia. And this is a reason why we taper off of SSRIs unless they're fluoxetine. So fluoxetine has a really nice long half-life, about 2.5 weeks. So it takes 5 weeks or so to really get out of the system. So that's another reason that I like to use that as a first line, because if we do need to change gears and think about a different medication, it really is you just stop the fluoxetine and start a different SSRI the next day, and that can be fine, and that can be very much tolerable for children and adults. In fact, fluoxetine has such a long half-life that it's sometimes used in discontinuation syndrome to reduce the severity of the symptoms. But when we're thinking about medications like Lexapro or sertraline, to just be mindful and to think about tapering off the medication. And if they're really adverse to taking the medication, if there's some issue with it where they really say, I can't take that medication, I won't take another dose of it, even if it's going to cause this, to then talk about using fluoxetine as an agent to try to step down away from the SSRI. So I've talked a lot about medications, and that's not to say that medications are the only thing that's going to help. Therapy is a huge indicator for success when we're treating depression or any kind of mood disorder for children. There was a 2004 randomized controlled study looking at treatment for adolescents with depression, and they split 439 patients, they split 439 individuals into 4 treatment groups. So one received 12 weeks of fluoxetine alone. Now, just to recall your memory, that's the acute phase. So we're just looking at the acute phase of treatment here. So 12 weeks of fluoxetine dosed between 10 and 40 milligrams. Cognitive behavioral therapy alone, and they only looked at cognitive behavioral therapy. And then they looked at cognitive behavioral therapy with fluoxetine, as well as placebo. So a sugar pill or other kind of pill that's equivalent to 10 to 40 without any psychoactive properties. And this is a summary of what this study showed. Now, each of these show the different outcomes that they were looking at. So they were looking at the Children's Depression Rating Scale. They were looking at the Reynolds Adolescent Depression Rating Scale. And they were looking at a suicidal ideation questionnaire. And the square on these graphs shows fluoxetine with CBT, so that's the combined treatment. The clear circle is the placebo, so you see the placebo is kind of towards the top here on each of these graphs. And then the triangle looks at just therapy, and the circle looks at just fluoxetine. So when you're looking at the depression rating scales, for those outcomes, they're pretty consistent between each other, that the the fluoxetine alone and the fluoxetine with CBT both outperformed the placebo and the CBT alone. You could see that there wasn't that much in the way of like error. So you see the box and whiskers are kind of tight to the data points here, to these points on these figures. So there's not that much crossover, which indicates that there was a significant difference between the two data points at the endpoint. But so in these two outcomes, we kind of see that being a similar result. When we look at the suicidal ideation questionnaire, we see a lot more overlap in these endpoints. So those box and whiskers are kind of overlapping each other. It's kind of hard to see whether or how different they are from each other. So what they found was that the CBT alone, this triangle here in the middle, and the fluoxetine with the CBT had enough overlap that it wasn't really a significant difference between just doing CBT or having CBT with the fluoxetine for those 12 weeks when it comes to suicidal ideation. So there might be some more to discover about that specific outcome as far as whether and how therapy versus medication or together or separately might impact the outcome, but there wasn't enough spread to really see significance there. So this is the end of my presentation. I just want to give you some of those take-home points, thinking back to the beginning. Really, assessment of mood is always recommended. The U.S. task force saying that it's not evidence-based before age 12, we do not agree with that. And in these slides, you'll find resources for different types of screeners and different suggestions for how to assess mood in younger children. We know that SSRIs are well studied and effective at reducing depression and suicidality. And I've provided some of the studies and some of the evidence that we have to make that statement. We do know that therapy and medication continues to be the gold standard for treatment. So I know that we have a lot of difficulty finding therapy, and that can often be the main that can be a big barrier to care for some children. So that makes us sort of think about these integrated models of care and ways to increase access. And then I've included a link here to the MCPAP clinical pearls for pediatric depression. So when you're reviewing these slides, you could always click onto the link here and take a look at the pearls that we have for you as a resource as you're continuing to review this information. So thank you all very much. I'm going to stop sharing.
Very nice. Very nice, Dr. Palmer. Thank you so much. So far we don't have any questions in the chat, but I'm sure there are things we can talk about. And maybe I'll sort of just kick off a little bit. And by the way, folks, Dr. Palmer may have to leave before 1:15 because she might have a patient that she has to see, but we're going to continue here until 1:15 as long as there are questions, and I'll be here to sort of try my best to field questions as well. Tell us about what are your thoughts, Sarah, about the risk of serotonin syndrome? That's something that you addressed, and I wonder what would you like pediatricians to know about particular drug interactions and sort of risk factors that could be associated with serotonin syndrome?
Yeah, so the main thing with serotonin syndrome is that if you're prescribing a SSRI at the recommended dose with the recommended schedule increase, that we don't expect to see serotonin syndrome unless the medication has been taken in excess. So one of the main safety things that I review is that, especially with children, that the parents are supervising all of the medication administration, so that a child does not accidentally take more medication than intended. And then, one of the there are some, and then I think that that is my main point with families, to try to make sure that they're assisting and supervising and storing the medication themselves.
Mm.
When we talk about the interactions at kind of a greater level, I sort of um, I don't have like a list of medications that I refer to as particularly high risk. I do know that some pain medications and anesthesia medications cause increase in serotonin. So if a child is going in for medical procedure, some of those common medical procedures like adenoid removal or something, it's just something to make sure that parents are aware of and they discuss with their doctors.
That sounds that sounds like good advice. And actually, I think we all rely more and more on our kind of algorithms, in our electronic medical records, to sort of steer clear of some of those interactions. But I actually like to make the point that SSRIs, even though it has, as one of the S's stands for serotonin, that the relative risk of serotonin syndrome for SSRIs is it's significant, but it's not as high as other serotonergic medications. For example, MAOIs, which are rarely prescribed these days, has a much higher risk. And I think sort of just being mindful of that. I actually there's a long list of the different P450 sort of interactions that can sort of result in people having higher concentrations of the medication in their bloodstream. But I think the main thing I like to sort of point out to people is that serotonin syndrome is real. It can sneak up on you. It's very dangerous and scary. I've had, cases over the years where I've kind of consulted on patients but only a couple, sort of for over 25 years, of practice. So it's not sort of a highly prevalent thing. But it's still very scary and can sneak up on you. There is a question from Dr. DeVere about mixing meds and therapy, and I think that and yeah, feel free to unmute yourself, but I think what the question is sort of aiming at is to see what your thoughts are about how sort of the prescribing of medications and the coordination and recommendation of someone receiving therapy, how those can interact with each other, particularly medications sort of undermining potentially sort of the confidence in psychotherapy and vice versa, sort of therapy potentially, sort of interfering with the effect of the medication. Yeah.
Yeah. I think that's a great kind of clinical question about how we practice and sort of what we do as far as increasing our bandwidth to make sure that we have a multidisciplinary approach when we're treating patients, especially when we're unable to provide that therapy ourselves if we're prescribing and unable to do the therapy, which is really the most often the case. So I think that having conversations with the therapist is really the best case scenario, where you're able to collaborate and get feedback from them and sort of assist in working together as a team. It does become a little bit of a catch-22 if the medication becomes sort of an object in the therapy when you're not present for the therapy. And then it can kind of take a life of its own. So it's something to be mindful of and to try to maintain those lines of communication open, but ideally it would be supportive to the therapy and vice versa. I think in an ideal situation, it certainly isn't always that way, and that's kind of a more complicated clinical question that would really depend on the situation. But I hope I'm answering the question. I don't
Yeah,
think there's any one answer.
So
it's a very complicated area. Oh, yeah, please go ahead.
can I? So I think, yeah, you both of you made great comments on this. I just wanted to add like one other additional little point is I think it really depends where the family is coming from, and you have families that are not interested in medications, and you have families that are resistant to pursuing psychotherapy. So I think seeing where the family is coming from is an important starting point. And the other thing I would say is, from my perspective, at a certain complexity level of depression, the role of the medication is really to make it possible to do the work of therapy, because that's what's going to actually impact the kid's life moving forward much more significantly. Sort of learning those skills, learning how to kind of manage, because this is sort of a risk for a lifelong situation. So if you make it possible by using the medicine to kind of get to a place where you can access therapy best, I think that's kind of what I go with when I'm trying to push that both might be beneficial. So, but I see that there are a ton more really thoughtful questions, so I don't want to.
Thank you so much, Yael, and I think that's a great point too. There's a question from Jan Scheuer. It says, can you talk about decision making around dealing with relapse or recurrence of symptoms in terms of switching to a different SSRI versus adding Wellbutrin? So that's kind of a decision point, that many of us face. So what are your thoughts about that, Sarah?
Yeah, so I think that it's a thoughtful question, and I think that it, like, again, a lot of this depends on the child and the family and their concerns. So I think that the first thing that I think about when we add another medication is that sometimes parents had a hard time starting the medication at all, and then we're adding something new, something else, and explaining the rationale can be a challenge, because it's, if this medication isn't working, then why are we continuing it, is the main question on families' minds when I'm talking with them at this decision point. So I think that the main question that I would have, if we're having a recurrence of symptoms and the child is taking a medication, for example, fluoxetine, I think that it depends on the length of time that the child has been taking that medication and how long it has been since their last dose increase, and whether they've reached really the maximum effective dose for a child. And for fluoxetine, depending on the age of the child, there have been studies going up to 60 milligrams a day. That's high. I don't think I have anyone on a dose that high or has needed to go that high, but that does give you a very nice range of offerings when it comes to adjusting the medication upwards rather than adding a new medication. So if this was a medication that was really effective at the beginning, they noticed a big clinical impact of starting the fluoxetine, and the specific symptoms of that recurrence are not things like anhedonia or feeling numb, which can be worse if we increase the SSRI. That would be a reason to go for fluoxetine. Like I said, if they're starting to feel numb, but their symptoms are otherwise under good control, that might be a reason to move towards the Wellbutrin. Also, a topic that a lot of adolescent males are not always willing to talk about as much is a loss of libido or any kind of struggle in their sexual, activities or behaviors. We do kind of try to normalize asking things about, how they're feeling and their comfort level, so that they can report if there's been a change in that arena, and that can be helpful, because if there is a loss of libido or loss of pleasure, we do tend to recommend Wellbutrin at that point, even if we haven't maxed out the dose of the fluoxetine or other SSRI.
Great points. I will add that the algorithms that we developed, which represent are the consensus for the MCPAP, sort of program, sort of really reinforce that point, that Sarah made, is really, trying to continue titrating, sort of really, I think our algorithms were designed to discourage polypharmacy, kind of, as long as, things are okay, and so sort of the adding of or augmenting, with a second medication, would be sort of the next line after you have titrated. And actually, we recommend two SSRI trials separately. And I think we're talking here about ineffectiveness or persistence of symptoms, during a trial as opposed to a recurrence. And I think recurrence can be a little bit more complicated. But I think I'll also remind people that Sarah made a really interesting point about adding Wellbutrin for a partial response where there's apathy. And so that's kind of an interesting approach. It's certainly, I mean, none of this is inconsistent with our algorithm because the algorithms kind of always remind us that patients are more complicated than, sort of what we, sort of how they're represented in algorithms. And so you can always call MCPAP, if you're not sure and if you're kind of on the cusp of making a change and you're not, have a confidence in, sort of your plan, we can kind of talk it over. There is a question from Janice Batista about sleep aids for kids on SSRIs, and I wonder if you could share some ideas about that.
Yeah, so my experience with sleep aids has led to me not really believing in sleep aids very much. So I tend to have families come in already trying melatonin, and the child is not sleeping. And the typical case is that the child has anxiety, and we start fluoxetine or Prozac, and eventually the sleep improves without needing sleep aid, because the anxiety during the day is reduced, and that allows the child more space to feel able to sleep. So I think that time, and patience is really the main recommendation that I make for families when it comes to sleep. I talk a lot about sleep hygiene and making sure that we reduce blue light exposure. If they really can't live without their screens for 2 hours before bed, to buy the blue light filtering glasses on Amazon for a couple bucks. I've made that recommendation. I also recommend that, we set an alarm for the morning and wake up at the same time, regardless of weekend, weekday, doesn't matter. We're waking up at the same time. Oftentimes children are sleeping in their parents' beds or insisting on the parents sleeping in the room with them. So we do talk about, creating a plan about how to approach that. Do we put the bed on the floor? Do we inch the mattress out towards the hallway? These are the kinds of things that have ended up being most helpful for my patients. When it comes to a sleep aid, if we're in like desperation and there's no sleep and the child is up throughout the night, really activated, that's a clue that, the medication is probably not the right medication for them, and we might need to revisit that decision. But, melatonin 1 to 3 milligrams, not every night, trying to use it sporadically will increase its effectiveness, and to really only give it right before bed. So, one of the most common things I hear is like, I gave them the melatonin at dinner time, we were watching a movie, they didn't fall asleep. Melatonin works the same way melatonin works in our brains. So if we stimulate our optic chiasm after we take it, it's going to reverse the effect in many ways and make it more difficult to achieve that sleep. So I do kind of talk more about behavior and sleep behavior than I do about sleep aid.
I really like those points. I think they're really helpful because the standard answer that you get to that question is, oh, just prescribe trazodone, melatonin, clonidine, Benadryl, Remeron, whatever. That these sleep aids are prescribed very, very commonly. And I think it's really important for us to remember that in kids, particularly, like when we give a medicine for sleep, that kind of really sets them up, for not developing kind of those skills, which they are skills, as far as sleep hygiene and ability to kind of settle down at night, and these are behavioral skills. They require structure, they require a team effort in families. They're hard sometimes to do. Sleep is so precious. You don't want kids going without a good night's sleep for too long, especially when they're depressed, because then they're not going to respond as well to their treatment for depression, and they're going to have other health consequences. So sleep is so important, and there's a temptation to just prescribe another medication. But in keeping with our philosophies in the program about polypharmacy, we I think agree, that it's best not to reflexively prescribe something for sleep as soon as you hear that someone's having difficulty with the sleep. And it's important to tease out, I think, whether the sleep disturbance is a side effect of the medication versus if it's a persistent symptom of depression, or if it's something that really predated the depression. That's kind of a baseline, kind of characteristic of the child's, nervous system and their skills and their environment. And, sleep is complicated, but I think that the answer, unfortunately, is nuanced. And sometimes, you might want to call MCPAP, to talk it over with us. The last question before we stop, and we do have to stop in a moment. I think it's an easy answer, or a quick one. Do you try a second SSRI before moving to Wellbutrin if there are sexual side effects? Or do you, just, move to Wellbutrin?
So I just moved to Wellbutrin. The SSRI is kind of the culprit usually,
Yeah,
unless the sexual side effects were part of the depression.
yeah.
So I just go to Wellbutrin, and I don't. It's fine. They work well together. It is kind of. I understand the polypharmacy conversation, but I kind of have an exception in my mind for this
Oh,
combo because it can
well,
help a lot.
well, Sarah, I think the question was whether someone should move to, switching to Wellbutrin, um,
Oh,
or adding Wellbutrin. I guess, yeah, either you might consider, right? Yeah.
I think it's an interesting. I wouldn't. I would change one at a time. So, like, if you have a medication, you have sexual side effects, and you add the Wellbutrin, and it's not helped by the Wellbutrin, I would then, uh, depending on what the SSRI was, I would cross tape or,
Yeah, yeah,
um,
yeah, yeah. So it's good
yeah.
to keep in mind that you have that option, that you're prescribing SSRI, then someone has sexual side effects. The first question is, is the SSRI helping the depression? And is that all good? And are we happy with that? And then there's a very simple move that you can make, which is adding a little bit of Wellbutrin to try to address the sexual side effect. If that doesn't work, then it's worth reconsidering, sort of going back and tapering, the SSRI, and maybe trying monotherapy with Wellbutrin. That's another option. But all these options, we try to boil it down to really simple algorithms, but it gets more complicated. So it's so nice to have this talk, and have a chance to hear from Dr. Palmer about how she approaches these things. But thanks so much, everybody. We really enjoyed the presentation. I really did, Sarah, and
Thank
I
you.
think it was well received, by the audience. And we'll see everybody next month, and we'll look forward to it, and hope everyone is well. Take
Thanks for
care.
having me.
Thank you.
Bye.
Bye.